Good afternoon. I'm sorry you can't see me, but there's some technical difficulties. But my name is Kay McCall, and I am the Vice President of Recruiting and Staffing at Aegis Therapies. And I've been with the company about 16 years. And I want to say thank you for joining us today. We have the opportunity to talk to 5 panelists that all have worked, they all work for Aegis, and they've all worked in a different types of post-acute settings that we're going to talk about today. So before we get started with the actual questions and answers about the settings, I wanted to provide a one-liner description of the 4 settings we're talking about today. The first is home health. Home health care services can be nursing or therapy and is provided in the home for an illness, an injury, or possibly a recovery from a hospital procedure that was done. I think everyone pretty much knows home health, but I just wanted to clarify. Then the next one we're going to be talking about is a skilled nursing facility. And a skilled nursing facility is a medical establishment that also provides both nursing and therapy services for patients. Maybe they've left the hospital but still have some need for some inpatient care that can be provided in the skilled nursing facility. And then third, we're talking about what we call CCRC, or Continuing Care Retirement Community. And these are campuses that provide each step of the continuum, from independent living, where people are totally independent. They may live in a single home, a small cottage, an apartment. Then the next step in the continuum would be assisted living, possibly memory care, where there's a little bit more support. And then the final in the continuum is a skilled nursing facility for short-term rehab and long-term care for the facility residents. The last setting we're going to be talking about, which is really growing, is direct bill outpatient clinic. What this is it's a direct bill clinic that's like a small clinic that's located inside one of those independent living facilities or assisted living facilities. And patients can be seen in the clinic or in any of the other areas of the facility. And then Aegis is the one that does the direct bill to Medicare. This has become a very popular setting for both patients, residents, as well as therapists. So with that said, those are the 4 post-acute settings we're going to talk about. But I'd like to have the panelists introduce themselves. And what I'd like you all to say, obviously, is your name and how long you've worked for Aegis and your title, but also what are the different post-acute settings that you have worked in? Because we're all experts in some way, and I want to make sure people get the questions that they can best respond to. So who would like to start? Mary, maybe you?
Sure, I would love to start. So I'm Mary Madison. I'm an occupational therapist by background. I've been an OT for 27 years, and I've been with the company for 17 years. During that time, I think I've done everything that Kay just mentioned. I started out on a CCRC as a PRN therapist. Did skilled nursing primarily, and then did a little bit of home health, and now I'm working in the direct bill outpatient clinics. So a little bit of all of it.
What's your title?
Oh, Director of Rehab. I'm a DOR for the direct bill division, multi-state DOR.
Very good. Thank you, Mary.
Yep.
How about you, Trish?
Oh, sure. Hi, I'm Trisha Howe. I've been with Aegis now, well, if you combine several years back in my 20s, which was just yesterday, combine it with now, I've been with Aegis about 12 years now. But my most recent time with Aegis, I started for 9 years. I was a regional director of HR for supporting DORs that worked in skilled nursing facilities. Love that. And now most recently, for the past 9 months, I am now an employment manager, and I support direct bill, the outpatient therapy part of our business, and am loving it.
Very good. Thank you. Thank you. Matt, how about you?
My name is Matt Schultz. I'm a physical therapist assistant going on 5 years now. Director of rehab right as of now for about a year with Aegis Therapies. I've worked for Aegis Therapies for about a year and a half now. I've spent pretty much all my time in skilled nursing facilities, pretty much since I started being a PTA.
Very good. Okay, then you're going to be our guru on skilled nursing facilities.
We'll see.
All right. Okay, Heather Burdick.
Hi, I'm Heather. I'm a PTA. I've been a PTA for 24 years. I've been with Aegis for 17 years. I'm the National Director of Home Services. I've been in pediatrics, but with Aegis, I've only done home health. I've worked with CCRCs, but mostly to support the home health.
Very good. Thank you. And Kylie.
Hi, everyone. My name is Kylie Ochterheide. I'm a physical therapist by background. I've been practicing 10 years, and I've been with Aegis 8 of those years. I'm a board certified specialist in neurologic physical therapy. And my current role with Aegis is a clinical practice specialist. So I practiced and support all of those areas essentially. So skilled nursing facilities, home health, outpatient within the skilled setting, and CCRCs.
Very good. So we've got a vast variety of experiences in post-acute. So what we're going to do is we're going to take it setting by setting. And I'll start with asking a couple questions of one main person, but then you are all welcome to chime in. So the first topic will be, or setting will be, the skilled nursing facility. And since Matt is obviously an expert, I'd like to know what you think after all these years, Matt, are some of the benefits to working in a skilled nursing facility.
One of the big benefits, in my opinion, is the continuum of care. So you see patients for much longer time than, say, in an acute care hospital setting. I feel like you really get to know the patient a lot more than, say, honestly, outpatient settings or acute care settings, because normally they're in that facility for a longer period of time. So they're subacute. We get to work on a few more things with them. Kind of more intimate with the patient because they are living in that facility for a long period of time. So we see their day to day. We get to talk to them a lot. And we also get a lot of, not to say this is the only place where we get a lot of different diagnoses in a skilled nursing facility. I've just seen a lot, whether it be TBI, stroke, spinal cord injury, weakness, developmental delay, orthopedic issues, stuff like that. So you really get to see a lot of different diagnoses, and you really kind of test your skill level as a therapist a lot in a skilled nursing facility. Not to say it doesn't happen anywhere else, but I just kind of like my area.
Okay. Well, I have no experience working in a skilled nursing facility, but I hear there are a lot of dementia patients there, and I've had no experience with those types of patients. Is there specific training that I will go through?
Definitely understand. Starting off, I feel like dementia is kind of more of a spectrum, I would say. I mean, you got some patients that, you know, they're technically classified as dementia patients, but you would barely know it through having a conversation with them. I mean, maybe they're just a little bit slower in the conversations than normally. And you definitely have those patients that are on the far spectrum that have a lot of cognitive deficits. Back to the question, you have a lot of basically learning, what's the word I'm looking for? Learning modules that you can look at. I think there's hundreds in our specific library for learning modules for dementia care. We have, all of our therapists have worked with dementia patients. When I started as a PTA, my PT assisted me greatly with dealing with dementia patients. So there's a lot of support available to help with dementia patients, and there's a lot of learning modules online that that are offered to assist with your dealing and treatment of dementia patients.
Okay. Well, speaking of training, I'm working in the school system. I'm a speech pathologist, and I've been working with peds my whole career. But I'm just fascinated by the wonderful ads and job postings I'm seeing from Aegis for all these hours with nice PRN premiums. And I'd like to come in the summer or even maybe on weekends to do some evals, but I have no idea if I'm even qualified since I have never ever treated there. I don't know the documentation system. So please advise me on this.
There will absolutely be a speech language pathologist to assist you in learning all the ropes in the facility, in whatever facility you will be going to. You'll have a lot of one-on-one time with that speech language pathologist to get you comfortable with working in that type of facility. I know it's a lot different than, say, peds, for example, completely different population. Obviously, our speech language pathologist will also be available via telecommunications for any questions you may have. Us personally, we have a great one that I love dearly. So honestly, there's nothing to worry about in your transition from pediatrics to skilled nursing facility.
Well, thank you. You've reassured me. For the other other panelists, before we leave the skilled nursing facility setting, is there anything else you want to add about what you like about it, the benefits, or or anything like that?
Sure, I'll jump in. This is Kylie.
Okay.
I feel as though in the skilled setting, it's really kind of your opportunity to shine as a true patient advocate. I think that was one of the things that really was very motivating for me, and where I really felt like I found my groove when I first transitioned into the skilled setting is learning how to be and championing that patient advocacy piece. I felt like that was just extremely fulfilling for me personally. I think these are a lot of patients that oftentimes are not able to advocate for themselves as you or I would be able to, and we, with a trained therapist eye, are able to be those eyes and ears for them.
Okay, thank you.
Hey, Kay.
Yes.
We have a question. Patricia would like to know, she says she's a new grad RN and an OTA for 14 years. I'd like to know about coming back to Aegis. I also had my LPN for 5 years.
Oh, wow. Who would like to take that one?
We'd love to have you.
Do it.
Come on back.
Well, where just come to mind.
Can we be a little more specific?
I guess
Oh, sorry, go ahead.
just to clarify, so she was an OTA and then went to RN, is coming back as an OTA?
Well, that wasn't clarified, but she was an LPN. She's now an RN, and she was an OTA.
Okay.
I believe for Aegis is what I got. She said she lives in Florida. From a recruiting standpoint, Kay, what would you say?
I would say she should contact Trisha Howe at aegistherapies.com. We have more than enough opportunities for her and would love to talk to her. So Trisha Howe would be a great source, and then we will make sure she gets connected with the right person and find out what kind of opportunities we have.
Yeah. And just to emphasize on what Kylie and Matt were saying, we have so many opportunities for mentoring and, resources to get you back into the game.
And I also have to say, I love the fact that you have the background that you do, not just Dakota, but as a nurse and LPN, RN, all of that is just going to add to everything. Like that just benefits our residents, all that life experience that you bring to the table. So yes, we would very much be interested in talking.
Yep.
With all of our new hires too, we go through a robust mentorship and training process, and part of that is doing a clinical competency assessment. So that's really an opportunity to identify both your clinical strengths, but maybe your clinical weaknesses, and deciding on what are critical skills, and then we develop opportunity plans on how to be able to make you feel as though you're competent to work and treat in those areas. So there's definitely a robust system in place if you feel as though you may be nervous about jumping settings or positions at all.
We also have a lot of
Thank you, and
sites in
thank you,
Florida
Shiloh.
that you can do. Oh, sorry.
No, go ahead.
We have a lot of sites in Florida that you could do a variety of things, where you could work in the skilled setting for part of the day and do home health for part of the day, following those same patients and having that variety too, which is, I think, a great benefit.
I have another. I am a PTA and would also am interested in working for Aegis as well. Have been a PTA for almost 9 years in the SNF setting. Can you please spell the name of the recruiter to email?
Yeah. You can email me at Trisha, TRISHA .how, HOWE, at, and Aegis Therapies is all one word, AEGISTHERAPIES.com. And I'm looking very much forward to receiving your emails.
Any other questions, Shiloh, for skilled nursing before we move on to the next setting?
Not at this time.
Okay, thank you, though. All right, thank you. The next setting we're talking about is home health. And I think many of you have done it, but Heather currently has a job, as we heard during the interview or the introduction. So I'm going to ask her some questions. So what are really the benefits of home health over the other settings, Heather? Come on, fill us in.
Okay. Home health is the best setting there ever is, I've got to tell you. And coming from pediatrics, you would think that it would be so different, but there were so many similarities as far as that patient interaction and the family ties that you are working together. So if you're coming from pediatrics, like you talked about, that speech therapist wanting to work for summers or weekends, like you can tie your skill set from almost any setting into home health. So don't let the lack of specific home health experience ever deter you from wanting to try out home health, because a lot of things will really tie into it. Home health is great because you get to work with patients in their living situation. You get to work one-on-one with them in an environment that is all theirs. And a big part of it is the honor of being allowed into their home to help them function in their day-to-day environment and work on goals that are very specific to them. And no offense to all the other settings, they're really great and all have their purpose, but you get to be there in their real life working on, let's say, getting their mail, right? So for everybody, getting their mail is different, and it could be taking the elevator down in their assisted living or their apartment building to get it out of their mailbox with their key, right? It could be reaching out their door to get their mail out of the mailbox that's attached to their house, or it could be, if you're in my neighborhood, walking down a pebbled driveway, a half a mile down the road and crossing the street with your walker, having to get your mail. And so for each of those different patients, it's totally different what you might be working on and hard to replicate if you're not there in their home. And so just think of all of the different goals and ADLs and different things that you would need to work on specific to that home environment, and how much fun it could be and how much creativity and variety that you can get throughout the day. I could go on forever, but I won't. But that's why I love it, just being able to be in that home with that patient one-on-one and working on those skills in real time, in real life. I love it.
Well, speaking of skills, Heather, what would you say is the skill set needed to be even considered a strong candidate for a home health therapist position?
Well, you have to be organized, right? Because you have to be able to plan your day. If you're just going to set out in the morning and not have your days scheduled and planned and your geography set, you are not going to be happy because you're just going to be driving around willy-nilly for patients, and your day is going to fall apart. You have to be able to pull together a day when somebody cancels and be able to pull other patients in. So you have to be able to have sort of this business mindset that allows you to manage your day like your own little business. So you have to be able to plan, like, these days I'm going to go to this part of town and these days another part of town, and be able to have a good rapport with your patients that, you know, they wouldn't call Mary in the outpatient clinic and say, I can only come to see you, Mary, on, you know, Tuesdays at 10 after my soap opera, right? But they'll do that when they're in their home. So you have to be able to finesse with them and get them to, you know, see you at times that, while, you know, you want to be respectful of their time, of course, but also not let them dictate the exact times because of their TV shows and things like that, right? So you have to have that good rapport and good balance with people to be able to do that and be able to manage your days and your cancellations to be able to fill those in so that you can manage your time really well. You have to be creative, and you have to be able to reach out for help when you need it. So if I need to call Kylie because I'm out of ideas what to do with this patient, she's my clinical person, or she's my supervising PT, like, I feel comfortable doing that. I'm alone a lot, right? So I need to be able to belong to Facebook groups and have other resources and use my peers and my mentors and all of my support systems when I need help or when I can't think of things because I don't have people right next to me in the same gym or in a different treatment room that I can go to. So it's things like that that I look for when I'm interviewing people, that can be sort of quick on their feet, that can be organized and creative with their days. Also, how to get out of somebody's home, because sometimes it's just that your patients are going to be so excited to have you there, or sometimes not at all excited, and you have to be able to work with that and go with that. You know, if they're not excited to have you there, how do you get them up and off their feet and get them working? And sometimes they are excited, they don't want you to leave. So how do you manage that time efficiently and effectively? So getting to know those kinds of qualities to get them into home health are important.
Okay. Well, you mentioned driving. So how much
Yes.
driving is there in home health?
Well, we do drive. We do drive patient to patient in home health. And sometimes that surprises people how much driving there is. The national average is about 15 miles per patient, which doesn't sound like a lot until you add up every day and 5 days a week. And it could be, you know, 400 to 500 miles a week. For us in Aegis, we tend to average less than that. We really work hard to densify and to, you know, create situations where we don't have as much, and we average, you know, right now today our average is about 10 miles per visit. Sometimes that's less, sometimes it's more, but that is, you know, there is an average, and we do drive. So you choose what kind of car you drive. I suggest I drove a Dodge Neon when I was treating full time. And I managed my day by planning it really well. And some days I had really great days, and some days I had really bad days. And overall, they balanced out to be pretty consistent with that, you know, 10 or so miles per visit.
Hey, Heather, how is their reimbursement for mileage?
It varies. You know, it's at Aegis, it's different than different companies, and it depends on where we are. So sometimes it's higher and lower, but at Aegis we do provide mileage reimbursement, and at home health agencies, or depending on where you work, sometimes it's part of your visit rate, sometimes it's the actual mileage, sometimes it's federal rate. It's just something that you have to investigate and think about. When you look at the mileage reimbursement and you compare it to how many miles you're driving and the tires and the oil changes and things like that, generally it does compensate you fairly, but it's hard to look at it when you're in the middle of it. Sometimes people get really hung up on the mileage, and I get it, I've been there, but when you do the math and you focus on the the management by fact versus how it feels sometimes. And it just feels like you're driving a lot. It feels like you're not being reimbursed. When you look at just the data, you'll almost always find that, you know, it does balance out equal or in your favor. But it's not always the easiest thing to do. But you will be driving. And so that's a part of home health. And if you hate to drive, it might not be the best. It might not be the best setting for you.
It sounds like I can see the flexibility and how attractive it would be for people who like to be independent and be outside. But if I have no experience, what kind of resources or support are available to me? I'm a really good therapist, but I've just never worked out of my car like that.
We have a lot. So we have peer mentoring between therapists that do have home health experience. Your manager, so our directors of rehab, will work with you on giving you all of we do ride-alongs. So we'll do at least a yearly ride-along, but before that, if you're new to home health, we'll do more coming in. You may do ride-alongs with your director. You may do ride-alongs with other people of your same discipline or your supervising therapist. If you're a newer grad or, you know, coming in without a lot of experience, we may have you work part-time in a skilled setting and part-time in home health so that you're not, so that you have some of that mentorship with somebody on site, things like that. We have a lot of clinical resources for our therapists. So not only do we have the videos in Relias and the support that way, but we have a lot of core programs and a lot of home health specific training. So there would be all of that. We have a competency checklist specific to home health that we go over. So there is a lot of support. And we never want our therapists to feel like we're just sending them out in the wild without that support. We want them to be confident and comfortable. And so it's not like they're ever out alone. They always have resources to fall back on.
I can certainly piggyback off of what Heather had described. I certainly am one of those resources within our company to provide that support and mentorship. So if I don't have the answers myself, I will find them and I will look to seek out the right individual to provide them. But definitely just want to echo and highlight what Heather said with the multi-layered support. She had listed many things there that are available. And so I do think that we can highlight the fact that we want to make sure that our clinicians are prepared and comfortable.
I have a couple of questions.
Okay.
Sure.
So as a home health therapist, do we need to purchase all of our equipment?
No, we provide the home health bags with the necessary supplies. Our customers sometimes supply some of that, what we call disposables or things that we throw away, but we supply the blood pressure cuffs and the necessary supplies that are required.
Okay. Do you have any settings for an OT who has a sincerely religious belief against vaccination, PCR testing, and masking?
That's not a me question. That is partially an HR question and a customer question. So we tend to, because we're a contract therapy company, we tend to follow our customers' guidelines. And I will say a lot of our customers are still in a CDC following those guidelines, and a lot of them most of them I would say are still in a masking policy as far as home health goes. And so we have a lot of exemptions for the vaccination for sure, but still in masking states. And I'm not sure about the testing, but it would be more of an HR. And as I said, we follow our customers' sort of guidelines on that. So I couldn't answer that specifically, but we would have to do like one-on-one questioning for that.
Well, I know personally, every time I go to the doctor, I have to wear a mask. So it is sort of a general healthcare thing, but you're absolutely right, Heather. We have a very busy exception process for COVID, but would be happy to talk to you and see if we can make a match somewhere for sure. I have to ask this last question, Heather, and then we'll open it up to anyone else who has more questions on home health. I have heard that in home health, you go into a lot of really dirty and scary homes, and I don't want to do that. Do I have to?
That's a great one. So I always like to start this one with a few things. One is all patients deserve care, no matter where they live. That's sort of my first discussion point, that there's people that live in places that are less desirable, that need us too. But that also counters the point that safety is my first concern. So the safety of our therapist is priority number one. I do ask my team to question themselves. Do you feel unsafe or do you feel uncomfortable? And think about that. If you feel unsafe, leave immediately, and we will talk about that at a place where you do feel safe. Don't ever not trust your gut. If you feel unsafe, get out of there. I've done it before, and I was the gal that got sent into the places that people did, because I grew up in a very urban area, and I felt very comfortable in areas that some people didn't. And so there was one time that I felt unsafe, and I left, and I talked about it later, and I never went back, nor did anybody else. And so those are the kind of how I start those conversations. We're generally not the first person in the home as a therapist, though sometimes we are. Often nursing will go in first and do the initial assessment and kind of feel out, what's going on. And so sometimes they, don't take them under care. And sometimes the house is dirty, but a lot of those reasonings might be because they can't change the cat litter, or they can't get the animals out of the house. And so there creates a bigger problem that we could help them with. It could be other things. And so trying to gauge what can we help them with and provide resources to make their environment more safe, and what can we not. But I will tell you that by and large, I go into far more homes that are mansions, lake homes, beautiful places, interesting homes, than places that are, really dirty. And like I said, in 17 years, one place that I felt unsafe. So just know that, as anybody should know, if you feel unsafe, immediately leave and call your supervisor from a place where you feel safe, and then we'll figure out the rest.
Okay. Any other questions from the group, Shyla, on home health?
I have a question and I have a comment. The comment is, that's a great arrangement for new grads to split between SNF and home health. And then the question is, as an RN/OTA, do you have home health positions?
So we don't own a home health agency. We are a contract therapy company, so we hire the therapist to partner with home health agencies. So we, as Aegis Therapies, would hire you as an OTA, but we partner with home health agencies that might hire you as a nurse, or have settings where you might be able to do both. So it's not something that we could do, could provide you an opportunity to do both for one employer, but it wouldn't be something that I see your point, and I would keep looking for that in areas with Aegis and perhaps a home health agency, or look for agencies that directly hire internally. That might be something very beneficial. There are rules around that, like you would have to do 2 separate visits, but you wouldn't necessarily have to leave and drive back, right? So you could potentially do a skilled nursing visit, and then do an OTA visit. They would just have to be time stamped separately, document, there'd be rules around that, but it might be something I have had a PT who is also an OT, who would on occasion do that. And so I bet it can be done, but that wouldn't be Aegis, if that makes sense.
I have a question for Matt. I'm going to put you on the spot, Matt. I know a lot of our skilled nursing facilities have home health contracts. Do you have a home health contract with your SNF?
Not mine yet. I'm in rural South Dakota, so it's a little more sparse out here. But I've definitely heard a lot of people doing, especially a little bit farther north, especially in Rapid City on the other side of South Dakota. I've heard of people doing, like, say, skilled nursing facility in the morning and home health in the afternoon. Just not in my area yet.
Okay. Well, it's definitely part of following the patient. And I know that's what a lot of clinicians want to do. So if they see them in the SNF after a procedure or surgery and then get to go to their home, it's better for everybody to see a familiar face. So
I
okay,
personally have done that role, Kay, and I found it extremely fulfilling, and the patients love it, their family loves it. To be able to see someone the day that they leave the hospital and follow them through the skilled nursing facility, through home health, into outpatient to come back to see me. And so it just really helps with that continuity, and that I'm a stable throughout all of that. And I can say it's extremely beneficial for the patient and very fulfilling as a therapist.
Very good.
Do we do teletherapy?
Oh, yes, we do. Yes, we do. Yes. So much so that we are hiring a director of rehab over telehealth for all of our 38 states. Currently, we have it all over the country, and we have about 10 or 11 100% remote therapists, not hybrids that go into the facility and also do telehealth, but these are folks who are dedicated. They're sitting in their homes, they have licenses in multiple states, and they do it. It has gotten to be such a need and such an interest on the part of candidates that we have decided to centralize it. So after we had a work group and now we've posted the position, we are in some final interviews with candidates that will be running a centralized department of 100% remote people, and they will assess the staffing needs of the company, and they will build a department that can help serve them, and we can go from there. Does not take away from local DORs that have their own telehealth and their own people that do both. It's just an extra resource in the company. So yes, we do telehealth. Absolutely. Okay, let's shift gears to continuing care for retirement communities. Okay, this is going to be a Mary Heather show at first. I'm going to ask you some questions because you volunteered, and of course anyone else can jump in as well. So I guess the first question is, I'm a new grad. What should I expect working in this setting where I've got independent living, assisted living, skilled nursing? Do I have to go to all of them? I mean, how do I do this? I never had a clinical rotation doing one of these. So help me understand.
I think typically in that scenario, typically we hire somebody into a particular part of the continuing care campus. But so you would receive the same, extensive orientation and mentorship that we talked about earlier, resources. So maybe you are hired into the skilled nursing portion, but then you would have the opportunity to assist in the assisted living or the outpatient or the home health. That would definitely be areas that you could grow into. I would say what you can expect is variety, just more of what Matt was saying, variety of diagnoses, variety of living environments and needs, and mentorship. You would be part of a larger team, so you would have more therapists in the skilled nursing, you would have additional therapists in the outpatient and home health. So I think it is a wonderful opportunity to be part of a continuing care campus, because you can be involved in all the different aspects of the patient. That can be very rewarding, but also you can learn a great amount, having those resources and that mentorship.
Okay. Well, I was worried about not having enough variety because, I'm a new grad and I am so smart. I have learned everything. So I want to be challenged, and I didn't know if I would get that in such a diverse setting. Can you tell me what my typical day might be in a CCRC?
I think, again, it's kind of similar to what we've talked about, where you might see a couple patients in the skilled nursing, and then you might walk over to the assisted living and see a couple of outpatients in the assisted living, and then maybe have a couple of home health. So I think as DORs, we try to initiate you in one particular area and really get you feeling solid and comfortable, and then kind of move you through the continuum, and getting to experience the other areas as well. So, but especially a great opportunity to do that is if you have a patient that you start with in the skilled nursing, and just like Kylie was saying, you can follow that patient, through the different steps of care. So definitely lots of variety.
Okay. Well, this question's for Trisha. This sounds really neat. I like this kind of setting, and I'm a really strong director of rehab. I've been doing it for 10 years. I've primarily been in skilled nursing facilities, but I know I could run a CCRC. So what does it take to be qualified for a DOR position in a continued care retirement center?
Well, first off, I want to say that I believe leadership is leadership is leadership. So if you're a DOR in a skilled nursing, a DOR in direct bill, a DOR in home health, I believe the qualities or the competencies that will make you effective are that to be extremely organized, to be always thinking ahead, like what needs to be done today, tomorrow, next week, the next month, to have excellent communication skills. And in that environment, even more so, because you are communicating in all levels and all areas. And I think the final one is emotional intelligence, having the ability to understand yourself, being self-aware, being socially aware, being able to read your customer, being able to read your employees, being able to understand your residents, and being able to really manage those relationships so that they're really effective. Now, in that particular, so that's leadership overall. If you're looking into a director of rehab, that's leadership overall. What competencies that we would be looking at. In that environment, I think it just, the organization that I believe it was Heather that talked about, I think that flows over in every position when it comes to being really good in rehab. And as a director of rehab, really being organized, setting your priorities, having excellent communication between the skilled nursing and the assisted living and independent living, and having excellent communication with your employees is extremely important. So I know I'm throwing a lot out there, but I do feel that leadership is leadership. Those qualities and competencies are important in every leadership role, even more so possibly in the CCRC, because you are managing all the different settings.
Okay, very good, very good. Okay, any questions, Shyla, regarding CCRCs from the audience?
I do have a question. It's not necessarily about that. What states is your company in? I know 38, but majors, more north, south, east, west. She is a CODA in Ohio.
We are there.
No.
And we are from New York to Hawaii. But I don't think I'm going to list them all. I'll be happy to get back to her. But it's our range is New York to Hawaii, and there's just a handful, obviously, that we are not in. Very big in the Midwest, very big in the West, very big in the Northeast. But we would love to talk to her because we have a lot of business in Ohio, for sure.
And again,
Okay.
Trisha.how@aegistherapies.com.
Thank you, Trisha. Thank you. Okay, then the last setting that we wanted to talk about, because it's very different. Not every rehab company does this, and not only is it really cool, we are just booming at this right now. It's really, like I said, where candidates want to be, therapists want to be, and also where patients want to be, our residents. And that is the direct outpatient business. And Trish is a recruiter for that, but does know all the other settings, as she said, and Mary is a director of rehab there. So I think if you could help us understand, Tricia, what should I even consider about outpatient therapy before I even put in my application? What are the benefits? What are you looking for? I mean, what's it all about?
So, honestly, I've been recruiting in this area for 9 months, and I just think recently I really began to understand the benefit of it. So, just for everybody's clarification, and you probably all understand this much better than I did, but we recognized that assisted and independent living communities would really benefit if they had a rehab team in that community, so that when that resident needs therapy, or when they need coming home from a hospital, or whatever the situation is, they don't have to worry about scheduling therapy. How are they going to get there? They have this clinic now right within their community. And how awesome. I wish I had that, how awesome is that? So that's number one. I just want to explain how it kind of works. It's a small clinic, and why should someone consider it? It is a very different experience than some of the other settings. However, as the other individual spoke about the other settings, I was thinking, we're all very similar in many ways. But the thing that I hear most often from my individuals that I've hired into direct bill is that they very much love the fact that they get to work really independently. It's a small clinic, like I said. So it's typically a PT, a OT, a PRN, speech, possibly some assistance, but it is a smaller team. And you really have to be comfortable working independently. And not only working independently, but really developing relationships in the community, connecting with residents, with their families, connecting with the community staffing, and really educating people so that they understand, I am here to provide care, therapy for these residents. I want to help them be as independent as long as they can be. Isn't that what we all want for our residents? And in this setting, that's what they really want, right? That's why they're living there. So developing those relationships. So when they think about, see a resident falling, see a resident struggling, see a resident struggling getting dressed, who are they going to talk to? They're going to talk to you, because you have developed those relationships, and you're going to get the referrals that way. So it's for people that like to work independently, for people that like to really connect, like to educate, like to market it. It's almost like marketing in some ways. So it's a bit different, because you don't have a schedule when you come in the morning, and that's all you do. We provide non-productive time so that you can educate, so that you can market, so you can develop those relationships. So I hope I'm answering your question. I think you had a couple questions at me and I'm talking a lot. But those are some
That's
of
okay.
but those are some of the things that I hear from the people that I hire into it and who have been in the role. They love the fact that they're independent. They get to identify the needs for the patients. They get to do the continuum of care that we've all spoken about, because we typically partner with a home health agency. And so the resident comes home from hospital, they need to be treated within their apartment. Our home, they provide home health there. And then once that patient reaches their level of care that they can go to outpatient therapy within the clinic, we can provide that as well. Once again, the continuum of care, which is everything that we've all been talking about, what Heather spoke about, what Matt spoke about. So all good things. So did I answer your question?
Thank you. You did. You did. Okay, this question's for Mary. Mary, how are the direct bill outpatient clinics similar and different than our SNF outpatient clinics? And why is it called direct bill?
So let's talk about similar and different. First of all, it's similar in the equipment. We have the heavier weights and more advanced balance exercises available to us. We have modalities. We do ultrasound, E-stem, hot packs, cold packs. So we really do set up a traditional outpatient clinic, just as if we were a standalone storefront clinic in the community, except we're putting it into the assisted living, independent living facilities. We have patients that are in the community. So in the SNF world, you see your patients in the SNF, and then they go home to home health, and then you have them come back for outpatient. So they're still needing some additional therapy, but they're living in the community. And our patients are as well. So they're living in their own apartments. They're going out and about in the community doing their thing and coming to us for additional strengthening and really to stay as independent as possible in the community. Some of the big differences, the space, the size of the gym is much smaller. These are apartment buildings. So an independent senior living facility really is an apartment building for 55 and older. So you go into an apartment building, there's not a lot of spaces for a gym. So we might share a fitness room, we might be in a private dining room, we might be in a 10 by 10 space. So we have smaller clinics. It just varies from building to building. Some of the other differences Tricia mentioned, she did a great job describing it. We have smaller teams. So you would not be part of, a 12 or 17 therapist team. It's much more independent, like home health. There's traditionally just one of each discipline. And so that's a little bit different. If you like being part of a larger team, this is something a little bit different. And we're getting the referrals. It's kind of a similarity to the SNF because our patients are all Part B. So in the SNF world, when you're working with Part B patients in the long-term care setting, you're doing your screens and things like that. And we're doing the same thing, but in the independent living facility, in the assisted living facility. So this is a great setting if you're a strong screener. If you're a strong therapist that really can easily connect with the residents in the community and identify the needs and be able to explain to the residents the benefits of therapy, because oftentimes we're hearing, well, Mary, I haven't fallen, and so I don't think I need to come to therapy. And I always tell them, well, we're not waiting for you to fall and get injured. We want you to come before you have a need for extra strengthening and beefing up your balance. And so so those are kind of I think that answers the first question. The second question, why are we called direct bill? So in the other settings, Aegis is contracting the time of the therapist, like Heather mentioned. Also in the SNF setting, we're contracting the time of the therapist with the customer, and the customer, either the nursing home or the home health company, they are transmitting the bills to Medicare, and they're billing Medicare and getting reimbursed for those services. In our setting, Aegis as a company is doing all of the billing. So Aegis is transmitting the bills to Medicare or managed care and getting reimbursed directly that way. So hence direct bill.
Very good. I have one more question for you, Mary, and then one
Yes.
for Kylie. I'm looking at the time, so I want to make sure we can get through and then see if anyone else has questions. But this comes up a lot in your business. What is the number of patients that is a full-time employee is expected to treat daily? And do you
Yep.
find challenging options to utilize your skills? So there really are two questions in there.
So the number of patients, we have the expectation for our therapists to treat 7 patients in an 8-hour day. So like Tricia mentioned, there is some non-billable time there to talk with the residents, talk with the physician or the families, gather that insurance information that we need to send into the billing department. Just like in the other settings, if the number of patients drops, then so does the non-billable time that you have available. So I kind of tell the therapist a good rule of thumb is 8 to 10 minutes. So if we have 7 patients in an 8-hour day, if you have 6 patients, then you subtract about 10 minutes. You have about 50 minutes of non-billable time, and so on down. And then what was the second question? Oh, utilizing your skills.
Yes.
I would have to say challenging. I don't think it's challenging. I think it's very similar to home health. So you're treating the patients in their own environment. And so it's individual. It's very client-centered. What are their needs? And that could be from very simply generalized weakness, building up their strength, to some things that are more interesting and more complex, like mental illness or low vision. So I think there's a lot of opportunity to really expand your skills and grow. I see lots of therapists growing their skills in taping, shoulder taping, things like that. We see a lot of pain and lymphedema certifications, beefing up their modalities. So I think there's a lot of opportunities for variety. So.
Okay, very good. Thank you.
Yep.
Kylie, last question from me.
Sure. What
and
is
that
it, Kate?
is, what are what are the clinical opportunities for growth and development in post-acute settings?
That's a great question. I think that's multi-pronged. So I'll answer it in 2 ways. I'll say maybe from what we have as opportunities as an Aegis employee, but then also industry-wide. So certainly, I can say that there's a lot of growth opportunities clinically. If you are someone who is driven and have a clinical niche area or a passion that you really want to be a champion of, whether that's home health, direct bill, skilled nursing facility setting, CCRC, there's opportunities in all of them. And then I would really encourage them to go through our Clinical Catalyst program. That's essentially a facility level clinical leader that takes direct mentorship and guidance from the director of rehab and myself, and to be able to utilize that skill set in a really targeted area, and then also to be able to build upon that and be the clinical leader in that area. Beyond that, we have the clinical practice specialist position, which I serve in, and we also have clinical directors. So I think that there's a ton of opportunity for growth. Outside of even that, we have a master clinician program that I'm also a part of. So I had mentioned early on, I'm a neurologic certified specialist. And so that is my passion, and I've applied and gone through a program to become a master clinician in that area within our company. But that's really an opportunity for someone, if you're an expert in low vision or prosthetics rehab or manual therapy, that you can pursue that and be that champion, you know, not only just within a close geographic area, but through telehealth support for our company. So I would say within Aegis, there's a lot of opportunities for growth to use your skill set, and really to embrace that culture of professional development. I always say if we stop learning, we become obsolete. So really committing to that lifelong learning program, we definitely can foster that. So outside of Aegis, I would say there's a lot of industry opportunities. So, you know, because I'm a PT, I'll speak a little bit more towards the PT side, but if you really want to dive in deep, you can go through a residency or a fellowship program. I personally have done a residency program after graduate school, and I found it just phenomenal. It was extremely beneficial for me to grow my clinical reasoning skills. But even within your governing body, so within APTA, there's a lot of opportunities for clinical support and growth. You know, there's continuing education opportunities, there's special interest groups, there's state and local chapters to become involved in, you know, whether it's you know, a patient advocacy or it's legislative changes that you really want to push for. You know, maybe it's a lymphedema certification. There's a lot of opportunities even within our professional governing bodies, you know, outside of even the Aegis culture. So I know that was a lot of information, but I think it's definitely a two-pronged approach. But I think the overarching answer to that is yes, the opportunities are endless. You just have to be willing to grow.
Hey, Kylie.
Thank you. Thank you.
Yeah.
How long did you wait in your career to get additional certifications?
I personally decided to do my residency right after graduate school, but that is not necessarily the requirement or necessarily the norm. Some people practice for a certain amount of years and then do a residency. As far as my NCS, I did wait 5 years, and I practiced and then I studied and sat for my exam.
Okay, it is at the top of the hour. In closing, I want to say thank you, Shyla, for managing the chat. Thank you, audience, for your questions. And thank you, panelists, for sharing your experience and your stories. And I'm sorry I didn't get to see, or you didn't get to see me, but I got to see you. So have a good night, and thank you for all the information. Appreciate it very much.
Thanks, everybody.
Thank
Thank
you.
you.
Bye.